presentation will be in English. Thank you, Professor, that you have a time, and we are very pleased to be hearing from you that you agreed to deliver a presentation at our conference. So, dear Professor, we thank you and eagerly looking forward, and the stage is yours.
Thank you very much for this elegant invitation and for the possibility to share with you several new data which we have produced regarding on how can we use the lab biomarkers in order to distinguish between bacterial and viral infection. So as you see, the title of my talk for this afternoon is Bacterial or Viral Infection, and the answer is consult the immune response. And if you ask what is the essence behind that, what are we need to ask the immune response about? Because the real problem, which all of us as clinicians have faced, is that in the majority of the cases, particularly when it comes to respiratory tract infections, we give treatment to our patients empirically, and there is no isolation of the real pathogen. So something has to guide us, and several times it is the immune response of the host which can give us the answer to that question. Here is my conflict of interest disclosure for the presentation. Please confirm that you can see my slides moving on. And allow me, first of all, to present you the burden of the problem. Here is a very obvious case of a patient who has sore throat, who has pus in the pharynx, in the tonsils, covering the tonsils. And the question is, which is the pathogens and whether antibiotics are needed. There is no doubt that in the majority of the cases, so far we know that epidemiology tells that the most common pathogen is a virus, but still what we have experienced is that there is overconsumption of antibiotics in these patients who are often treated with antibiotics, and this leads to emergence of resistance. But allow me to bring you to something which is much more common, particularly during the winter months. A patient with medical history of chronic obstructive pulmonary disease, he comes to you and tells you, I have started coughing and have sputum for the last 48 hours. And this is his chest x-ray. And all of a sudden, you ask yourself, is this because it's viral? It is because it's one of these pathogens which you can see on the screen, Streptococcus pyogenes, Haemophilus influenzae, Mycoplasma pneumoniae, or it is the most common pathogen, which is a virus. However, how many of us would have the daring just doing that only to decide not to prescribe antibiotics? All of a sudden, the concept about consulting the immune response of the patient to guide treatment changed in 2004. Why 2004? Because all of a sudden, the concept which was generated suggests, imagine that you have a patient who does not have an infection. If he does not have an infection and there are no clinical signs, the blood PCT should be low. But if a patient develops an exacerbation of a previous disease, let's say that he had viral disease and now again he has a new respiratory exacerbation. If PCT remains low, that means that there is no bacterial component. In other terms, all of a sudden, it was introduced for the first time that you can use a biomarker to decide when to start antibiotics, when to stop antibiotics, or where there is no need to change antibiotics. And as a matter of fact, the idea regarding when to start antibiotics was framed into an algorithm, where on top of the algorithm is what the history of the patient and the condition of the patient, and this is judged by the physical examination, suggests. And if procalcitonin is less than 0.25, then it's not suggested to give antibiotics. If it's more than 0.25, then you have to give antibiotics. But in order for the investigators to establish that, there were in need of a randomized controlled trial. In other terms, patients with respiratory tract infections were arriving at the emergency department and they were split into two. Half of them were treated with a strategy which is represented in this graph as blue. In other terms, they were receiving antibiotics as usual, whereas those in blue were obliged to obey to the rule of procalcitonin. And as we can see, we have here the comparison regarding the percentage of the patients who were on antibiotics, irrespective of the final diagnosis, was community-acquired pneumonia, exacerbation of chronic obstructive pulmonary disease, or bronchitis. Guidance by procalcitonin managed to decrease the necessary prescription of antibiotics. This was followed by another 3 randomized trials, which had exactly the same design, suggesting that if you use procalcitonin, you manage to decrease the consumption of antibiotics, but there is no risk for the patient and no change over time. However, the time goes on. After 2009, where the first randomized control trial for procalcitonin came out, there is no other randomized control trial for a biomarker if we have to use or not to select antibiotics. But we need to take into very serious consideration that the data which I showed to you for procalcitonin are data who have been done and generated almost 20 years ago, and the last 20 years, the resistance profile in the community have changed. So, probably, we have now to see what is published regarding the biomarkers, which nowadays, with the current resistant microbes, which are spreading in our continent, are the biomarkers which may differentiate between bacterial and viral infection. Let's see why this is so important. When there is infection, the liver plays a major role. Why? Because on the liver, you identify the Kupffer macrophages, which they stimulate the production of IL-6, and IL-6 in turn leads to the production of C-reactive protein from the liver. Parallel to that, when there is viral infection, Kupffer cells, they produce interferon alpha, which leads to the production of IP10. That means that you need to measure IP10 and CRP in the bloodstream. And if the balance goes towards the IP10, this means that this is viral infection. If it goes to the end of CRP, this is bacterial infection. But you are in need also of a third protein, which third protein can make the situation softer. But when you use 3 proteins, all of a sudden, the cost of the reagent goes up. Indeed, there is a type of assay, point of care assay, which can be used at the level of the emergencies, and which measures on the same side IP10, CRP, trail, and ends up with a score. And the more the score is towards 100, that means that the patient is suffering from bacterial infection. The more the score is towards 3, it means that the patient is suffering from viral infection. So there are several studies out there with that tool, and the first study was called Curiosity. It took place in children and adults, and in all these studies, and the studies which I will later also presenting, the important question is, which tell us who's the patient who suffers from bacterial infection and who's the patient who suffers from viral infection. And this gold standard is provided by expert adjudicators. In other terms, you collect experts. At the end of the trial, you give to them the file of the patient. You give to them the exams of the patients, with the exception of the exam, which is the test exam that you want to validate and evaluate. And you ask them, Do you believe that this is bacterial or viral? So if you look at that, you see that the more this CRP, the more likely the infection is bacterial, the more the procalcitonin, the same thing, but if you add them all together, then that score that I presented to you earlier is towards 100 in case of bacterial infection and towards 1 in case of viral infection. The next study, and the more recent one, was called Observer. It took place in 415 patients in Israel. Again, adjudicators were used. And here you see the comparison of that assay, the MIMED assay, compared to CRP, two cutoffs of CRP, 20 and 80, and procalcitonin for bacterial and viral infection. And it turns out that the assay behaves better in terms of both sensitivity and specificity compared to CRP and procalcitonin. But what is very important when it comes to this type of assays, that you see that they do not all of them behave the same for the same pathogen, particularly when it comes to viral infection. Others, they stay low for any virus, but you see that when it comes to respiratory syncytial virus, the assay provides much worse reading readout compared to influenza, alpha, beta, or rhinovirus. So now allow me to bring you to another interpretation of the immune host response. Interleukin 6, as we said, leads to the production of CRP, but interferon alpha and beta, which are produced in case of viral infection by Kupffer cells, they interact with the respiratory epithelial cells, giving rise to what we call the myxovirus resistance protein A. MEX-A is the acronym. So, we are facing the last 10 years a change of our concept on the epidemiology of respiratory infection, particularly of community-acquired pneumonia. And we got that lesson from the famous EPIC study, which took place in 3 states of the United States and enrolled more than 2,000 patients. And actually, what was found there was that all patients with lower respiratory tract infections, they suffer from mixed infections. And as you will see there, some patients with community-acquired pneumonia, they have 2 viruses. Some patients, they have 1 virus and 1 bacterium. In other terms, what you need from the assay is not to tell you if the infection is bacterial or viral. It needs to be able to detect if you have in front of you a patient with mixed bacterial and viral infection, because mixed bacterial and viral infections, they also should receive antibiotic treatment. These are data from the EPIC study. These are more recent data coming from our group, again in patients with community-acquired pneumonia, using biofilm array, and confirming the fact that the majority of cases of pneumonia are mixed infections, either 2 viruses together or 1 virus and 1 bacteria. So, what we need from a biomarker is to be able to cover all that entire trajectory of respiratory infections. And for this, we need a type of development which is completely different than any other biomarker, and that type of development which we call stepwise development, one step after the other, we elaborated in order to develop MEX-A CRP, both of them together in one assay as a readout of whether the patient is suffering from bacterial or viral infection. Of the first step, we follow, first of all, for these biomarkers, to be of importance and for the studies to be of importance, you need to know that we do not get blood from the patients, follow up the patients, and make the measurements at the end of the study. We need to do the measurement at real time. And this is difficult for a study. And the most attractive of the stepwise development which I present to you this afternoon is that the measurements were done real time. So, first question. We want to know if a patient has definitive viral infection and definite bacterial infection, nothing else, which are the cutoffs which tell for certain that this is a definitive viral or a definite bacterial infection. Then we need to move to go to a setting, because definitive infection means that at step one, we had patients with positive microbiology. Now we move to step two to see in an environment where the microbiology, the molecular microbiology was negative, if the cutoffs are working. And as a third step, to apply the cutoffs in the reality of mixed infections, both viral and bacterial. And finally, because bacterial infections, particularly pneumonia, are lethal, can these cutoffs predict the outcome of our patients? So first step, and this is a publication of last January of my group. It's a multi-center study in more than 500 patients across Greece. We have 40 controls, no infection, 136 patients with definitive viral infection. In other terms, we elaborated molecular microbiology to identify the viruses, and 131, which was molecular microbiology, we identify bacteria. So definitive viral infection means viruses and nothing else. Definitive bacterial infection means bacteria and nothing else. Now compare the groups. The SOFA score increases as we move from controls to definitive bacterial infection. The same applies for white blood cells, procalcitonin, and also for mortality. And we know that the difficult to treat infections are the definitive bacteria. So the SOFA score, the white blood cells, the procalcitonin, the mortality, they confirm that indeed they were infections impacting the health of the patients. So now we want to identify a cutoff which can differentiate between bacterial and viral infection. In blue, our patients are the measurements of PEX-A. In red is the measurement of CRP. You see that in patients who are controls, both of them are down, but in patients with definitive viral infection, note how increased is PEX-A, whereas it's exactly the opposite with CRP in case of bacterial infections. And now we elaborate cutoff, which is combination of a probability coming from a machine learning, or in case where you don't have that possibility, the ratio of PEX-A to CRP. And when this is less than 2, this points toward bacterial infection. If it's 2 or more, it points towards viral infection. And you see that with that approach, you have a negative predictive value of more than 90% not to miss a bacterial infection, and a sensitivity of more than 90% to select the correct patient who's in need of antibiotics with definite bacterial infection. So, in patients with clear-cut infection, this cutoff works. Now let's move to patients to whom have negative microbiology. But after reviewing their files, the adjudicators said 11 of them are at high probability of viral infection and 128 are at high probability of bacterial. And again, you see the same thing. SOFA score, white blood cells, procalcitonin, and mortality, they point the bacterial infection. So what the adjudicators, they said, were correct. Indeed, they managed to pinpoint the most difficult infections. And look at here. In highly probable viral infection, MXA is sky high. But in high probably bacterial infection, it is the opposite. And if you apply the cutoffs, again, you get here a more than 90% positive predicting value to do the correct thing. Let's move now to step 3. A very common scenario to daily life. Patients co-infected. 20 of them, the molecular microbiology identified both a virus and a bacterium. In 71%, virus was identified, but the adjudicators, they said that this patient has probably bacterial co-infection. And look at the SOFA score, the white blood cells, the procalcitonin, and the mortality is similar to these patients. Why? Because they have co-infection. And MXA and CRP are equally active in these two groups. Final. As we have already showed, bacterial infections, they bring high risk of death. So, can we identify the cutoff of our MXA CRP tool, which can tell from the very beginning, from the emergency department, who's the patient at early risk of death? Look at the comparison of MXA between survivors and non-survivors. MXA is much higher in survivors. But when it comes to CRP, it is again the opposite. Non-survivors, they produce much more CRP than the survivors. So, let's get a ratio. XA to CRP less than 0.15 and XA to CRP more than 0.15. When it comes to death, you are in need of high specificity, high negative predictive value, so that you rule out the patient who's at risk to die. And indeed, with a ratio more than 0.15, you may safely rule out the risk of death. And this is the value of your bionet. As a matter of fact, you see that an odds ratio less than 0.15 increases by 2.55-fold, statistically significant, the risk of death. With that, I hope that I managed today to show to you that we are in front of us of a different future, a brighter future, where the guidance of treatment and antibiotic selection for respiratory tract infections should rely on point-of-care tests. There is no doubt so far that the majority of the studies are available for children. But what you need to know, and I would like that you remind the demographics of our patient population which were enrolled in the MXA-CRP, that our study in MXA-CRP is the largest ever conducted in adults. And the idea is that one edge is viral, the other edge is bacterial. I integrate the information I get from the biomarkers using artificial intelligence, and the readout I get from my device is the likelihood that the patient is suffering from bacterial or viral infection. And this may guide antibiotic prescription. I would like to insist further on the MXA CRP tool. Why? Because there is high sensitivity and high negative predictive value to discriminate bacterial from viral infection. And this is translated into safe guidance for antibiotic prescription because of the high negative predictive value. If the ratio is favoring MXA CRP, it's more than 2. That means that the chances that you mistake that the patient has bacterial infection, in other terms, that you may misguide and not give antibiotics, is really minimal. So, if the ratio is 2 or more, don't give antibiotics. However, you need to interpret not just the ratio, but each of them separately. And if both of them are increased, this indicates that the patient has a mixed bacterial and viral infection, and because of that, he should receive antibiotics. And also, the ratio less than 0.15 suggests that the patient has a risk of death. In other terms, if it's more than 0.15, the ratio can rule out death. Perhaps someone would say, what is needed further? There is no doubt that the randomized controlled trial is needed in order to study how the guidance for antibiotic prescription relies on MXA CRP. But before that, and until this is done, the data which I showed to you and I shared with you today are the largest data available so far for any adult population. Thank you very much for your attention, and I'm looking forward to the discussion.